that you need pretty large doses of drugs to end somebody's life. In fact, killing people it is not easy and straightforward at all. And these are not doses of drugs that you would ever normally prescribe. And I question whether you really need a doctor to prescribe these at all, given that in medicine, we're titrating medication to try to get benefit. Whereas here, all you want is the harm from the drug to end life with no therapeutic benefit to the person. So I think before you even contemplate a change in the law, and it might sound as if it's very liberal at the moment, and it seems to be something that some of the Western countries are pursuing, you need to ask, does the law really need to change? Would you be better with this, or are there dangers? And I will go through those. And you can talk about assisted suicide, where a doctor isn't involved at all, or physician-assisted suicide, or physician-administered euthanasia. Now, we have over 500,000 deaths every year just in England and Wales, and it's a very small number of people who are calling for this. But when the law changes, you do seem to get a change in society, which I will go on to in a moment. In our society, we need to think, are there limits to our choices? And if you pursue one choice, do you endanger another? And I would remind you that we have a duty to prevent suicides. And if you suddenly say, right, well, for this group of people, we're not going to prevent their suicide, we're going to assist their suicide, what do you do to the whole ethos of medicine? People seem to be asking for this out of a situation of fear that they, fear of the future, fear of things that might happen more in a way than the present. Oregon went down the road of assisted suicide, physician-assisted suicide, 23 years ago. And in their latest report, they've recorded the concerns that people expressed at the end of life. And it's worth noting that pain and concern of pain was way down the list. It was very low down. The top of the list were less able to engage in activities that make life enjoyable. And then third on the list, 53% of people were worried about being a burden on family or friends or caregivers. These were social concerns, not medical concerns. So I say pain was way down. And of course, you all know that the pain experience, as well as being physical, is all made worse by emotional, social, and spiritual turmoil. Those are things that need to be looked at. So, do we ever kill our patients with morphine? Well, I would say no. You titrate morphine to be above the level of pain and below the level of toxicity. Giving morphine, or even if you get side effects from morphine, that's not euthanasia. This is titrating up analgesia to get on top of pain. Some people need more than morphine, and they need nerve blocks. They may need other modalities if they have complex pain. And of course, they need psychological support. But titrating up morphine is not euthanasia. Is stopping treatment euthanasia? No, it is not. You don't carry on with the treatment if the risks and the burdens are greater than the benefits. People consent to treatment and can withdraw consent at any time. Stopping treatment is not euthanasia. It may be stopping something which is burdensome, which is futile, and is now having no benefits. There was a famous case in the UK of someone with motor neuron disease who had campaigned for euthanasia, but then our law hadn't changed, and he decided he did not want to carry on being ventilated. The ventilation was stopped. It was all planned. He was at home. His doctor and nurses were there. They took him off the ventilator. They controlled all his symptoms using midazolam, a small amount of morphine, and kept him comfortable during the time until he died. He died of his motor neurone disease, or ALS, as it's called in many parts of the world. He died of the ALS. He did not die because the ventilator was stopped. He would have died long before from the disease without the ventilation. He died of the underlying disease. The ventilation had kept him artificially alive. That was not euthanasia. Euthanasia is where you give lethal drugs, that massive overdose I've spoken about, deliberately to bring about death, months or weeks before it would have otherwise occurred. Now, what do the pieces of legislation say? Well, in the UK, we have a piece of legislation put before Parliament at the moment. It's a private member's bill. It's not a government bill. And it requires the following criteria to be met: that the High Court would consent. Note that it must be voluntary. The person is over 18. They have the mental capacity to make the decision, and they're terminally ill. And of course, they're resident in the country. That this isn't about tourism for death. Similar bits of legislation have been introduced in other places. This was a draft bill that was put before the Irish Parliament. And there's similar types of wording have gone in different countries around the world. I think it's notable that these are all highly developed Western countries. They're not other countries in the world. And I do worry about what's happening in our so-called developed societies, which are actually becoming fragmented. So one of the difficult things is, how do you define if somebody's terminally ill? Well, you can't. You can't say certainly that somebody's terminally ill. It's a balance of probabilities. In this piece of legislation, it's been defined as a progressive condition that can't be reversed by treatment, and the person's expected to die within 6 months. Well, there's a problem with that too. And interestingly, they've said treatment that only relieves symptoms is not to be regarded as treatment that can reverse that condition. So think about your type 1 diabetes patients. They are dependent on insulin. Insulin controls their symptoms. It doesn't take the diabetes away. It doesn't make their pancreas worse, but it relieves all of the symptoms from which they would have died if they didn't have insulin. Without insulin, they would die within 6 months. So they would all fit this definition. And indeed, that is the definition that had been used in Oregon, and someone called Fabian Stahler had questioned that and had pointed out that most diseases become terminal if patients refuse to take their medication. So your type 1 diabetes patient would fall into this category because there is an assumption that the illness takes its course without the treatment. So your type 1 diabetic patients would all be eligible in this type of legislation. Now, I was on a select committee and we looked at the various criteria, and we heard from the pathologist that in almost a third of patients, people died of something different to what was written on the death certificate. And in 1 in 20, there was a misdiagnosis. As for prognosis of 6 months, we were told it's pretty desperately hopeless as an accurate factor. And there was a Liverpool Care Pathway used in the UK for a time to try to provide care for people in the last 72 hours of life. And even when they were thought to be in the last 48 hours, 3% improved. We are pretty hopeless at accurately predicting that either prognosis or even always making diagnosis accurately. And remember, if you change the law, you're expected to be completely accurate. The law is black and white. It doesn't have room for, well, probably, I think, and so on. What about the mental capacity to make a decision that you're Well, if you're depressed, if you're on different medications, all that impairs capacity. And many diseases, many of the neurological diseases, motor neuron disease, Parkinson's, and so on, all impair cognition. It looks simple, but actually to make the biggest decision you could make, which is to end your life, you need maximum mental capacity. But importantly, we're not very good at assessing it. And the most important is, of course, it must be your own wish. But remember, people's wish to die and wish to live fluctuates. I told you already, people are frightened of being a burden on the family, and we don't know what goes on behind closed doors. How many doctors on this conference have thought that they had a loving family in front of them and they knew everything, and they've then discovered afterwards that there was deep unhappiness, coercion, control, all kinds of terrible things, including abuse, going on behind closed doors. And how long does a settled intention have to be settled? We don't know what goes on in those homes of our patients. We only see them for a few moments in front of us. I'm going to skip past this for time, but these are other things that are meant to be safeguards in the law, such as having a second opinion doctor, but actually that doesn't act as a safeguard. And telling people what you could do is different to them experience what might happen to improve their situation. The drugs that have been used for assisted suicide, well, they used to use barbiturates in the US, but they became in short supply. And so they've used odd cocktails of diazepam, digoxin, morphine, and amitriptyline, I think designed to induce an arrhythmia. And interestingly, they take longer for the patient generally to become unconscious and to die than with the previous mixtures. But these have never been subject to a proper clinical trial. They're rather experimental. In Canada, there's been experience that people with disability are now not getting the care that they need. There are concerns about it. The UNHCR, the United Nations Commission on Human Rights, inspected and said, I'm extremely concerned about the implementation of the legislation from a disability perspective. And this man, Roger Foley, went to court to try to get the arrangements he needed to live well. And he was told he couldn't have those funded, but he was free to pursue a medically assisted death. This is a young girl who had been very depressed. She'd been abused in childhood, a lot of psychological illness. And in fact, in the Netherlands now, 83, oh, I'm sorry, I'm backwards. In the Netherlands, 83 people had now had euthanasia just in 1 year on grounds of psychiatric suffering. So things really change, expand, and now mental illness is used as a criteria to provide euthanasia or assisted suicide. What happens to the numbers around the world? Well, they seem to escalate everywhere. There are some places now in the Netherlands where 1 in 19 of all deaths, all causes, are from euthanasia. Similar numbers are thought to be present in Belgium, where we know that now about 40% are not reported by the doctors. They find the paperwork burdensome. In Canada, the numbers have gone up quite steeply. They've escalated. And in Oregon, the numbers have risen fast as well. And in Oregon, they only have physician-assisted suicide. They don't have euthanasia as well, because the federal law of the US seems to prohibit euthanasia, but individual states have allowed assisted suicide. But the numbers are nearly tenfold once you get euthanasia there as well. In other words, it's easier for someone to say, oh, I put my arm out and doctor, you inject the lethal drugs, than it is for someone to pick up a glass or all those tablets and swallow them all and wait then to become unconscious. There's something very passive about submitting to euthanasia, which I think makes it more likely to expand. And people who are frightened what lies ahead may think, well, I'm dying, I'll just get it over with now. Are there unintended consequences? Yes, there do seem to be. There is moral injury. There are descriptions now from doctors, particularly in Belgium, of feeling traumatized by repeatedly performing euthanasia. I've had discussions with doctors who describe how they mentally block these cases out. It's as if they're traumatized by the process and then they block it out of their consciousness. I've spoken to doctors who have been worried as to whether they took the right decision in agreeing to euthanasia, and many situations where the family pressurizes for euthanasia rather than actually the doctor thinking that this is the right thing to do. There does seem to be a decrease in support for people with disability. This was a headline from the Washington Post saying that Canada is plunging towards a human rights disaster. And it does seem that palliative care developments slow up since 2012. There has been little increase in palliative care developments in countries that had already gone down the road. In some places, there's initial money put into palliative care, but of course, without the staff, without the training, the expansion just doesn't really happen and it dwindles. The other thing is that clinicians find that even if there's been a conscience clause written in legislation, in practice, that really doesn't work. It doesn't apply because dying patients are everywhere in all services, and people encounter this and feel that they have to be involved. So I would suggest to you that this is not a medical duty. This is not what we trained in medicine to do, and that to start going down this road is extremely dangerous. We need to be looking after patients. We need to be doing what we can for them. But to be deliberately ending patients' lives long before they would have otherwise ended is not a job for doctors and is too dangerous. So I see that we've got some things that have come up in the chat. And I was just going to have a look to see if are there some introductions that were written in the chat. I thought they may have been questions that had come up. So I hope that outlines for you some of the problems that there are with trying to change the law. And I hope it clarifies that this is about deliberately giving a massive overdose of drugs against some criteria which are actually very arbitrary and cannot be clearly verified. And I'm very happy in the few minutes that we've got left to take a few questions and have some discussion, because quite often the questions are the most interesting part of any presentation. Thank you. Perhaps if some people have questions, they might either pop them in the chat or raise a hand if that's possible on the system. Dr. Joshi, perhaps.
Yes, Professor, we'll just wait. If someone has any questions, you can raise the hands. All the delegates are requested. If you have a question, please raise your hand and we'll take your questions.
I think looking at all the names on the screen, Dr. Joshi, it looks as if people are all in India. I wonder if anybody here is working in one of the other countries where the law has been changed, and if they wanted to share their experience.
Professor, I can see Debota is here. She's from Nigeria. Debota, do you want to share something with us from your country?
There in Nigeria, they certainly don't have have euthanasia legalized. It's the same criteria as we have. But I would be interested to hear from her as to whether this is a discussion that's happening in Nigeria.
Debota, if you're online, you can unmute and discuss it with us. If not, you can also put your views on the chat box if you're not able to communicate through your mic or anything.
I think that for any country, anywhere, doctors have to be very clear about what their duty is. And one of the problems that's happened in many places is that the law has been changed and doctors haven't protested enough. And then they find that this is lumped on their shoulders, that they are suddenly expected to administer lethal drugs and control them and manage them, but with no more resources, no support, and really expected to carry the responsibility, which is a very, very burdensome responsibility. And it makes you like the state executioner in many ways. We've got rid of the death penalty in most countries around the world, and thank goodness that we have. And then all of a sudden, you put the doctor in the position then of ending life, which is an enormous responsibility, particularly when you've been striving with all that you've done to either save somebody's life or to improve the quality of their life, or both. And certainly in palliative care, the whole ethos of that is to improve quality of life, to try to make things better, to try to make each day better for the patient, accepting that they will die of their disease, but you try in each day to help things to be a little bit brighter and easier. And so it becomes really a reversal of that philosophy when you suddenly say, well, the doctor is now going to be the person who comes along and gives you lethal drugs.
Professor, I had a question.
Yes.
What could, like in your opinion, what could be the implications in terms of training in medical education when it comes to euthanasia? Because we do not see doctors, at least in our country, we do not see doctors prepared for such things.
No.
So what could be done in that aspect?
I think, Dr. Joshi, that's a very important question. And in the countries that have changed the law, there also was no anticipatory training. That all seems to have come after the event. It's very much that it's dumped on the shoulders of doctors. I think that the most important training for you at this stage is to understand the enormous burden of what would be put on your shoulders and empower doctors to say, no, this is not a medical duty. And also to empower doctors to say, we need more support to do the job we have to do. We don't have spare capacity in our systems to take on something else. And I think to be able to argue very clearly for making sure that, for instance, analgesic prescribing is available everywhere. There are still parts of the world where prescribing morphine is extremely difficult. That needs to be corrected, that needs to be available. There are many places where doctors are working with very inadequate support. They don't have enough support from nurses, they don't have enough additional medical support, they don't have secretarial support for the job they have to do. And you know, I think that we have to be much more clear in saying what our role is in society, and that we need support to do it. And that our role is to look after everybody, irrespective of their social background, their social standing or whatever, but that each life is valuable and our role is to do the best we can to improve the quality of that life. I see Farhana has put in the side, bar euthanasia is strictly prohibited. And I'm glad to hear that in Oman it is. I think it is really important to have a clear line. The thing that the Netherlands and those countries have shown us is once you take away that prohibition, then it becomes very easy for the boundaries to be moved and changed, and it can become a convenience. And Lokesh Vaishnav has asked, is euthanasia needed? And I would say, in terms of changing the law, no. There will always be one or two difficult cases that you encounter during your professional career where you really feel stuck. You don't know what to do. The first thing, of course, is to always seek help from other colleagues. There is no shame in asking for help from other colleagues. There is shame in being too arrogant to ask for help. So phone somebody up, talk to somebody, get advice from somewhere. And there will always be some patients where you worry that you could have done things differently, but that's the burden of responsibility that we carry. What I've been talking about is where the law changes to make it a medical duty to be involved in deliberately ending life. And I find that very worrying indeed. Oh, Dr. Reddy has a hand up.
Ma'am, I really enjoyed your talk, but my one question was, most of your talk focused on active euthanasia, which I totally agree with you that should not be in hands of our doctors. But what about passive euthanasia, which is now legal in India?
Okay. What has been called passive euthanasia is stopping treatment when it is futile. That allows you to not carry on giving a treatment which has no benefit. I don't like the term passive euthanasia. I don't think it should be used because I think all you are doing is accepting that the person is going to die of their underlying condition. Whether it is their disease, whether it is after an accident, you're accepting that they are dying and you're providing support and care while they're dying. You're not just walking away and leaving them, abandoning them, but you still provide some basic care, but you stop whatever was the main intervention. So that was the example that I gave you with stopping ventilation in somebody where it was not achieving any goal. It was not achieving an end. And it was accepted that he would have already died from his disease if he hadn't had the intervention. So I hope that that clarifies it. That's completely different to going and injecting a massive overdose of lethal drugs. Does that help, Dr. Reddy?
Yes, ma'am, it helps. Ma'am, so passive euthanasia would be helpful in a resource limited setting, right? Because we have limited ICU beds, we have limited ventilators, and it also causes distress to the relatives and the doctors when continuing life support for months together is not achieving any progress.
Yes, I would advise you, Dr. Reddy, to try to avoid the phrase passive euthanasia, because it becomes very easy for politicians to flip that into active euthanasia and start to think that you should give lethal drugs. But yes, around the world, there are limits. You know, we can't ventilate everybody. So you have difficult decisions to make, and you ventilate the person who is the most likely to benefit from the ventilation. And of course, you can't predict either. So you think somebody will benefit, and then it turns out that their condition deteriorates so much that it isn't a benefit. And then you may have to take the decision that you're going to stop and withdraw ventilation and free up the ICU bed for somebody else who is much more likely to benefit.
I totally agree with this, ma'am. This withdrawing life support when necessary should definitely not be falling under euthanasia. It should be given a different term. Thank you very much, ma'am.
Yes, thank you, Dr. Reddy. And I'm very grateful to you for asking that question, because it is a very, very important question that you've asked. And of course, you are particularly resource restricted in some parts of India, but in many parts of the world, people are really short of resources. They even have to decide who will get the morphine as analgesia when it's running low. I know in hospitals in the Philippines, for example, they quite often have very small supplies of morphine. So they can't give adequate doses even of morphine to people in pain. The rationing problems in medicine are severe.
Also, Professor, it's very recently, even in India, the supply and prescription of morphine was very strictly regulated under the Narcotics Act that we have in India. And it was very recently that a movement was started in Kerala that Pallium India, it took up the cause that morphine should be made available to the patients as a measure of palliative care. So I think there are, from what I understand, the entire discussion, what I understand is there needs to be advocacy at multiple levels. One, to clearly define what euthanasia is. Second, not to contradict with the current role of healthcare professionals, which is to save lives. So it becomes very difficult to make the doctors in training understand that on the one hand, they take the oath to save the lives, and on the second hand, on the other hand, they have to also take a decision when to end someone's life. So that becomes very tricky. And third would be about how we define euthanasia. I think when we are using these terms, active or passive euthanasia, it might actually get us caught up in a lot of terminology, and ultimately leading to what the leaders or the political diplomats might have in mind, and shrug off the responsibility, or I would say shift that responsibility from probably law or the legal advisors to the healthcare providers. So that might be an additional burden. Thank you.
I think Dr. Joshi, you're absolutely right. You're spot on. And I would suggest that you should only use the term euthanasia where you're actively injecting lethal drugs into a patient in order to kill them as quickly as possible. And that for other terms, you should talk about a person who is now dying. Use simple terms, they are now dying, or they are now only receiving palliative care as they die. And we must accept death. Death is inevitable. but it is about natural death. It is not about killing people.
Sure, Professor. Dabota, I can see you. Do you wish to share anything?
Yeah, thank you very much. In Nigeria, morphine is very scarce. We hardly see it. For instance, in my hospital, I've never seen it's not available. I know it's available in just 2 tertiary hospitals, the largest hospital we have in Nigeria, University College Hospital in Ibadan and the Lagos University Teaching Hospital. It's very scarce. So, and because of the religious and cultural beliefs in Nigeria, euthanasia is not practiced at all. It's never practiced in Nigeria. For now.
Yeah. Yeah. Well, I hope that it never is, Dabota. I hope it never is, but I think that you certainly do need to have morphine available. It will make care of patients easier. And I think that it is a real problem in many, many countries, particularly across Africa, that there is such a scarcity of the availability of morphine. And it is a really straightforward way of providing good analgesia. But people are very frightened about addiction. They're frightened of it leaking into the non-medical use in addicts, and that's a real problem. But actually, when you use morphine for severe pain, it's pretty good. It's a good drug. I would have really found it difficult to practice medicine without being able to prescribe morphine in particular. Yeah.
Thank you, Professor. I think, and thank you, Dabota, for sharing your perspective on this. I think we do not have any further questions. So, Shreya, would you want to conclude?
Yes, sir. Thank you. I would like to thank Dr. Elora Finlay, ma'am, for joining us today for this session. And I know that she has a really busy schedule, but she really took her time and she made sure that we really understood what euthanasia is, because it's a really confusing concept for all of us to grasp. And she made it really easy. So thank you, ma'am. Thank you so much.
Thank you everyone for joining. Thank you, Professor. Thank you all the delegates for joining. We'll be ending the session, this session, and we'll move on to the next one at 4 p.m. IST. So we'll see you then. And yeah, thank you.
Thank you so much.
Yeah. Piyush, can you please end the session?
Will do.